Good afternoon, everyone, and welcome. My name is Roxana Sultan. I am the Vice President of Health at the Vector Institute in Toronto. Today's session is being recorded and will be posted to the Vector Institute YouTube channel. Though this webinar is being brought to you virtually today, we are each located in a particular place that has a history, traditions, and stories that are old and should be honored. I join you today from the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. At Vector, we believe that Canadians have an unprecedented opportunity to harness world-leading artificial intelligence research and innovation to build on the data advantage stemming from our public health system and our diverse population. Vector enables its partners in the health and academic sectors to implement leading-edge AI research to support better whole life health. Access to health data for discovery and care purposes remains a persistent challenge to enabling a learning health system. Privacy-enhancing technologies, or PETs, are a rapidly evolving area of study and application. They show promise in providing technical solutions to accessing health data and minimizing privacy risks. To that end, I am pleased to welcome you today to our session, which we hope we will gain a better understanding of some of the more promising PETs and their potential for application in the health domain, as well as some of the barriers and enablers to implementation. Before we begin, we'd like to get a better sense of your existing level of understanding of PETs. Please take a moment now to respond to the online poll, which will aim to understand a little bit more about your understanding and your current knowledge of PETs. While the poll results are coming in, I would like to acknowledge and thank Vector's funders, the Province of Ontario, the Government of Canada through the Pan-Canadian AI Strategy administered by CFAR, and our industry sponsors from across the Canadian economy. Speaking next will be our moderator for today's webinar, Dr. Melissa McCradden. Dr. McCradden is a bioethicist with the Department of Bioethics at the Hospital for Sick Children. She holds a PhD in neuroscience from McMaster University and a master's in bioethics from the University of Toronto. She was the inaugural postdoctoral fellow. My apologies. She was the inaugural postdoctoral fellow in the ethics of AI in healthcare with SickKids and Vector Institute. Her areas of scholarship and research include artificial intelligence, machine learning, precision child health, pediatric bioethics, and research ethics. She is particularly interested in how to responsibly evaluate these new technologies from an ethics perspective, integrating research ethics and evidence-based medicine. This work involves exploring the accountability of clinicians, informed consent in pediatrics, and public, patient, and family perspectives about AI. Melissa will frame today's discussion and then introduce a series of short presentations by each of our esteemed panelists, followed by a Q&A. I believe the poll results are in. Thank you very much for all of your responses. And with that, I will now turn it over to Melissa.
Thank you so much, Roxana. I'm really excited to be here today. Thank you to all of those who have logged in. As Roxana said, the goal of the webinar today is to provide you with an overview of emerging techniques to preserve privacy in healthcare data. They're called privacy-enhancing technologies, or PETs. And because we're talking about healthcare, it's first worth thinking about why privacy is so important. Data scientist Deborah Raji, in reflecting on her work tabulating the COVID death counts, wrote in the journal Cell in 2021, "Data are not bricks to be stacked, oil to be drilled, gold to be mined, opportunities to be harvested. Data are humans to be seen, maybe loved, hopefully taken care of. Data science is human subject research." And nowhere is this more true than in healthcare. People don't tell their best friends, their spouses, or their children what they tell their doctors. And what they tell them gets written down in a medical record that serves as a substrate for data-driven research activity. It makes sense that people are generally sensitive to how and where that information gets used. However, our desire for privacy, when left unquestioned, can hold us back from using that information to help others. In many other areas in healthcare, such as infectious disease, pediatrics, and others, we know that an individual's right to privacy must be balanced against the potential for others to benefit from what that information might reveal. It's also important to know that many of the data that are considered private, like visit dates, age, especially in pediatrics, and other potentially identifiable features, are actually essential to doing machine learning right. And without them, we lose a great deal of the social value of research, which is one of the key criteria by which research is determined to be ethical. Historically, a minimizing approach has been taken to address Canadians' privacy concerns. However, there's widespread recognition that not only might this limit the value of research that is conducted with health data, but also that our current de-identification processes are not as robust in the present era. For this reason, privacy-enhancing technologies aim to protect individual-level privacy with respect to the identifiability of an individual within a dataset. And while there's no current standard definition of pets at this time, what they all generally aim to do is to be consistent with current privacy legislation, to minimize the amount of data that can identify specific individuals, and can enable individual control over the information about themselves. And the webinar today is intended to bring this audience up to speed with some of these emerging technologies. As we apply new approaches, we want to think about a number of issues to really reassure ourselves about the nature of this trade-off. How do pets work? How can we be reassured that they do work? And what do patients and families maybe want to know about how their data is handled? So today we'll hear from three prominent scholars in the field of pets regarding specific methodologies that show great promise in the healthcare space. First, Dr. Papernot will introduce his work on approaches that preserve privacy and confidentiality in collaborative settings while maintaining good technical performance. Next, Dr. Bruno will discuss approaches to data federation, enabling the preservation of privacy by sharing information about models rather than individual level data. And finally, Dr. Rudzicz will present work on obfuscation of data using two relatable examples to demonstrate the application of these technologies. And with that, we'll get started with our first speaker. Dr. Papernot is an assistant professor in the Department of Electrical and Computer Engineering and the Department of Computer Science at the University of Toronto. He's also a faculty member at the Vector Institute, where he holds a Canada CFAR AI chair, and a faculty affiliate at the Schwartz-Reisman Institute. His research interests are at the intersection of security, privacy, and machine learning. Thank you, Dr. Papernot.
Thank you for the introduction, Melissa. I'm very happy to be here. And before I get started with the talk, I want to acknowledge our funding and the sponsors that are generously supporting this research, including CFAR, for providing us open-ended funding that allows us to explore these new research directions and new ways to protect privacy. So to motivate why we should care about privacy, I wanted to give an example of an attack that we've been working on with my students on data that is essentially used to train machine learning models. And here the idea is to say, once we've trained a machine learning model from a sensitive data set, and we've mentioned things like healthcare data sets that we might be interested in learning from. The idea behind this attack called membership inference is to tell whether a particular point that we have access to was used to train the model. And so you could imagine that if the model was, for instance, trained on medical data to predict, let's say, readmission to the hospital, being part of the data set is itself sensitive information. And so what we've shown in this work is that an adversary that is able to only observe the labels that a model is predicting is able to tell whether a particular point was used as a training point or not. And so you can see how even with very limited access to the model's prediction, you're able to infer very sensitive information. And so to protect against these forms of privacy attacks, there is really one definition that has emerged in the technical community as the gold standard for protecting privacy, and that is differential privacy. Here, the idea is to say that the algorithm that we're running to analyze our data should not be influenced too much by any of the points that are in this data set. And so more specifically, what we're saying is that an adversary that is observing the outputs of the algorithm, so in our case, the outputs of the training algorithm, shouldn't be able to tell whether we were operating on a data set that includes a particular record, here this green record that corresponds to one individual, or if we are operating on this other data set, which is identical, to the exception that it does not include that particular record. And so you can see that if an adversary is unable to observe these predictions and infer whether we operated on this data or this second data, then they cannot tell whether the person existed or not in the end. And so the privacy of that person is preserved. And so how differential privacy formalizes this is by looking at the probability that the algorithm makes its different outputs and showing that these probabilities are very close on these two data sets that are themselves very close. And so this is what is at the bottom of the screen. In the interest of time, I'm not going to go into the details of this definition, but what is interesting to note is that it introduces a parameter called epsilon, which quantifies how indistinguishable these two situations are. And so what is good to know is that when you're looking at differentially private approaches, the lower the epsilon is, the stronger the guarantee of privacy is, because the harder it is for an adversary to distinguish these two settings. And so there are several approaches to obtain differential privacy in machine learning. I'm going to introduce one here called PATE, because it makes it very easy to understand intuitively why differential privacy is such a great definition for privacy. And the idea behind PATE is to say, if we have an initial set of data that we'd like to protect the privacy of, we're going to split this data in multiple partitions rather than train one model on this initial set of data. We're going to first split the data in these n partitions such that these are mathematical partitions. There is no overlap between them. And we're going to train one model from each of these partitions. What this means is that we now have an ensemble of n different machine learning models that were trained independently from different data sets, but that all perform the same task. And so we can ask ourselves, how do we get these models to predict while protecting the privacy of their training data? And the idea here is to say, well, I'm going to aggregate the predictions of these models. So I'm going to send them an input and then ask them to vote for the label that they'd like to assign. And once I've done that, if I reveal only the label that received the most number of votes among these teachers, then I get this intuitive notion of privacy because the prediction does not depend on a single teacher, not on a single of these models, but rather it stems from a certain form of consensus. So this is true that it provides intuitive guarantees, but it doesn't provide differential privacy quite yet. And the reason is that there are edge cases where one of the models changing their prediction will lead the aggregate prediction to change. So for instance, you can think about a setting where maybe half of the models would vote for one label and half of the models would vote for the other label. Then just one teacher changing their predictions might result in the label that is assigned as the label receiving the most votes might change from one class to the other. And so to protect against these edge cases and obtain formal differential privacy guarantees, we have to randomly perturb the votes that the teachers are submitting. And that allows us to prove that this noisy voting mechanism is differentially private. And so we can use it to answer queries without leaking private information from the initial training set. And so here, what I want to stress is that this form of privacy guarantee is very strong. And in particular, it doesn't depend on what the adversary knows. And so this is a very strong limitation of anonymization approaches where you're trying to decide what are the sensitive pieces of information that we'd like to remove from the data before we consider it to be anonymous. These approaches have been shown by the technical community to not work in the long term because the adversary will gradually gain access to auxiliary information that allows them to de-anonymize the data. And so here with differential privacy, we're able to obtain a defense that limits the privacy leakage of the model and in a way that is robust to adversaries gaining more capabilities in the future. And so here in this slide, what I'm doing is comparing differential privacy with other approaches that have been proposed to sort of obfuscate the confidence of the classifier as a way to prevent attacks like what I've discussed in the first slide, like membership inference attacks. And so previous approaches basically propose to mask the confidence of the model and show that this prevents existing membership inference attacks. But what we showed in this work is that if the adversary is able to perform what we introduced as label-only membership inference attacks, then they can evade all of these prior defenses because they now rely on a different signal to extract the private information. Whereas in the same paper, what we found is that if one does train the model with differential privacy, then this differentially private model is robust to the attack. It actually gives the best trade-off between the accuracy of the model and the privacy of the model, despite the fact that we have trained this differentially private model before we were even aware of how to mount these new forms of label-only membership inference attacks. And so this shows you that this is really a very strong guarantee that we're proving for the algorithm, and that it is robust to a lot of very strong forms of attacks, and even attacks that have not been designed yet. And one advantage of the Pate setup is that it lends itself pretty naturally to a decentralized setting. So let's imagine we have a network of hospitals, and they each have basically data that is already partitioned. You can imagine that each of these partitions is already a hospital in some sense. And so they have a local set of data for which they've trained a model. And what they're interested in is collaborating to basically get the ability to collaboratively predict on the same input without sharing their data or without sharing their models. And so what we introduced in the CAPC protocol is a way for hospitals to do that with strong guarantees of differential privacy from the Pate framework, but also with cryptographic primitives that allow us to get confidentiality, which here means that the data or the model parameters stay secret. So they are not shared between the different hospitals. And the way that it works very quickly is that a hospital that is interested in having the other remaining hospitals predict on their input will take their piece of data, encrypt it, and send it in this encrypted way to the other hospitals that they'd like to get help from. These hospitals are going to use something called homomorphic machine learning to infer on the input without having the ability to read it. And then they're going to use the output of this inference, which is still encrypted, and centralize it to build basically this histogram of votes that I was referring to in Pate, again, in a fully encrypted way. And then we are going to reveal to the querying hospital, the initial hospital that submitted the request, the noisy argmax, so the label that received the most number of votes, that is output by this histogram. And so what this means is that the hospital that submits the piece of data for help from the other hospitals does not have to reveal this piece of data. So we have protected the confidentiality of that data. The responding hospitals do not have to reveal their models. So they can rest assured that their models remain confidential and do not leave their premises. And then through the noisy voting mechanisms, we've also protected the privacy of the training data that these different hospitals used, which means that the label that we are revealing to the initial hospital does not convey private information that would be, for instance, specific to one patient that one of the hospitals would have used in their training set. And so this gives us the ability to take existing models that may have heterogeneous architectures and have them collaboratively predict in a fully decentralized way. And in our experiments, we even found that this allows us to improve the fairness of the predictions, because collaboratively, you can imagine that these different hospitals have different data sets that are slightly sampled from slightly different distributions. And so by aggregating their predictions, you get higher fairness. And one last advantage compared to techniques like federated learning is that none of these hospitals have to agree to commonly train a single model that they all share. They each get to retain their own model locally, and they can even improve these models locally without sharing the models in any way. Okay, and so the last part of the talk that I wanted to cover today is sort of asking the question, now that I've advocated for differential privacy, is it a silver bullet? I will say that it's not a silver bullet because it does not correspond to all of the forms of privacy that you may be interested in. And a particular example that has attracted more attention recently is the right to be forgotten and the ability for users to request that their data be deleted from the training set. And so in this work, what we've shown is that differential privacy does not completely answer this problem, because while it prevents privacy leakage by bounding how much information potentially leaks from the machine learning algorithm, it doesn't mean that the machine learning algorithm does not learn anything at all from each of its training points. In fact, it learns a small amount from each of its training points. And so we are not quite there yet, in the sense that with the right to be forgotten, we want to guarantee to the user that the model that we've obtained no longer contains any information that was derived from their point. And so this is particularly difficult in the context of deep learning, because the algorithms that are used to train deep neural networks are iterative and stochastic, which I won't get into the details, but that makes it a lot harder to obtain erasure of the training set. And so the way that we obtain this guarantee is by proving to the user that the model that we obtain by first learning from their point and then unlearning their data is coming from the same distribution of models than if we had not learned from their data in the first place. And the way that we obtain this guarantee, and I encourage you to read the paper here for more details, is by first splitting the data in multiple models, as was done in Pate, which allows us to limit the impact of each training point to a smaller model, but also change the order in which we analyze the training data, so that it's easier to save intermediate states of the model that do not contain influence from particular training points. And what this means is that we can use these intermediate states of the model to reverse the model back to a state for which we know it had not been influenced by the point to be unlearned. And then we can resume the training of that model from that intermediate state without the point to be unlearned, so that we obtain a new model that does no longer have any influence from the point to be unlearned, but still has very good accuracy. This overall process takes a lot less time than if we had to recreate the entire model from scratch without the point to be unlearned. So with this, I'll conclude by saying that another aspect of privacy, which I encourage you to think about, is the possible tensions that it creates with fairness. Because in fairness, we want to maximize the performance of the model across different subpopulations. And with privacy, we want to prevent ourselves from learning from examples that we have very few examples of in our training set. And so there are sometimes tensions, and this is something that we've looked at with my fellow researchers at Vector. On medical data, these tensions are particularly more likely to occur because the distributions in healthcare tend to be heavy-tailed. And so these tensions between the privacy and the fairness are more likely to arise. With this, I'll leave it open for questions, and I won't take more time since I know we're on a tight schedule.
Thank you so much, Dr. Papernot. We are having questions come in, so thank you so much for submitting those. What we'll do is we'll move through the talks and we'll have a question and answer period at the end. So with that, thanks. With that, I'll introduce our next speaker, Dr. Michael Brudno, who is a professor in the Department of Computer Science at the University of Toronto, as well as the Chief Data Scientist at the University Health Network. He is also a faculty member at the Vector Institute and the Scientific Director of HPC for Health, a private computing cloud for Ontario's hospitals. His main research interest is in the development of computational methods for the analysis of clinical and genomic data sets, especially the capture of precise clinical data from clinicians using effective user interfaces and its utilization in the automated analysis of genomes. Thank you, Dr. Brudno.
Thank you for the introduction, Melissa. Thank you for having me. Hopefully folks can see my screen. So I'm going to talk to you today about data federation, and one way of thinking of it is it's social distancing for your sensitive data. And I'm part of an initiative called Candice, which is aiming to connect in a federated manner Canada's health and genomics data sets. So we'll talk about that a bit as well. So when we talk about healthcare data in Canada, it's naturally federated because healthcare by Canadian legislature is provincially regulated, and every province has can make completely independent decisions about privacy trade-offs based on its population's own choices. Even when you are able to centralize the data, different provincial statutory and regulatory requirements make it difficult to do. And because Canada is a federation, it understands the issues with data federation, making it easier for us to adopt a federated computational model to look at data. So sort of as a quick side note, what is a federation? So in government, a federation is a union of self-governing provinces, states, or regions that share power between a centralized authority and the regions themselves. And each region has some control over its internal affairs, while common issues are managed centrally. In computational speak, federation is a set of network systems that agree on specific standards of operation in a collective fashion. So this ensures compatibility of communication between multiple systems so that they can talk to each other, they can send data back and forth, and they know what to expect when data comes from another site. Federations look in many different ways, so many different kinds of political federations and many different kinds of computational federations, and each has specific trade-offs. Federations could be built in a way where all data is centralized. All data is actually brought together, but in very specific ways, and then a user would interact with the single repository of data. The data could be actually kept at individual sites, and this is the model that we're going to talk about the most. And then when the question arises, the various nodes have to share data with each other in order to build the answer for the user. This could be also supplemented by having an exchange mechanism where the queries get centralized first and then sent to the individual entities. And the reason federation is attractive in the healthcare settings and broadly is that there are multiple things you can do with data while it's federated, while it's staying at independent sites. You can do federated analytics, answering specific questions about data that's present at different sites. So here a user, for example, could get information about this blue genome and about this green genome just by asking the questions and asking the nodes to communicate among themselves to get the answer without having direct access to this data. There's also federated machine learning, where a common machine learning model can be built based on data that is located at different distinct sites, where the model that is built actually is reflective of all the data at all of the sites rather than of any data set, of any specific data set by itself. And the model can then be used to, the federation can then be used to deploy the model to the sites to keep on improving the model. So the little keyboard advice feature that you get on your phone, that's an example of a federated machine learning model. It learns based on what you type, but also based on what millions, hundreds of millions of other users are typing on their keyboards to give you suggestions about what word you may want to type next based on the first few characters. So one thing though that I think it's really important to disambiguate, federated learning or federated analytics are not private. Just because you're keeping the data separately at different locations and you're only allowing relatively harmless queries to be sent, these, if repeated, can leak very sensitive information. So one example that was in the news maybe 3 or 4 years ago, there's GA4GH, which I'll talk about more, came out with something called the Beacon service, which allowed for queries to be sent against databases that really answered very, very simple question, which was, does your database have a patient with this mutation or not. It was just a simple yes/no answer that was sent back. And it was very quickly shown that even though one such query really didn't reveal much information, doing a relatively small number on the order of about 20 such queries would allow you to, with very high certainty, answer the question of whether a specific genome is part of a database. So if I had somebody's genome, I would be able to say, are they participating in a specific study? And that's obviously a significant leak of information. For federated machine learning, this is also not private because machine learning models can memorize sensitive data. And making the model federated does not change this. So even though you're only sharing the weights of the model, by learning a common, bigger model, it will have aspects of the data that came in from each individual site. And this is just an example. The more complex the model, the more likely it is to memorize data. This is an example from recently published where the GPT-2 model, which is a large scale language model, was prodded with a prefix and basically started spitting out potentially sensitive information that related to the provided data set. And by the fact that only weights are shared, or only only the weights of the model are shared rather than the raw data, this does not change. Now, there's a little asterisk next to the no. Both federated analytics and federated machine learning can be made more private through techniques like homeomorphic encryption and differential privacy, which Nicholas just spoke about. An example of making federated analytics private. So if we have, for example, a query that we're going to send around, each hospital or each data custodian could decide to add some noise to the response. And when the user gets the response, they're actually getting an approximation based on which they would not be able to know the exact answer at any individual site. And the joint result is not directly interpretable. And each user needs to get a privacy budget for their queries so that they cannot just query over and over and over and get more and more accurate answers. So, however, despite this, hospitals really like data federation. And the answer is and the reason why that is that data privacy is a game of reducing and not eliminating risk. So we're never going to get to 100% privacy. We're never going to get to 100% guarantee that data is not going to be leaked. But federation helps to reduce the potential risk. It gives local control. Each site can decide when, how, and with who to share data at whatever granularity level that they wish. It gives participating sites confidence that they can withdraw data, while Nicholas mentioned the fact that it's hard to remove the data from the trained model. They can at least make sure that no future models can benefit from the data, and this is a key component of research ethics approval at pretty much every hospital, is that users can withdraw from future studies, even though they cannot withdraw from studies that have already been completed. The other advantage is that it provides for privacy and data visiting. It gives some confidence that shared data is not fully identifiable and makes it simpler to negotiate cross-border collaborations. There's less to worry about when it comes to thinking about laws of other jurisdictions, because the most of the data is staying with you, and what's going to other sites is not fully identifiable and easier to negotiate with the lawyers. So CANDIG, the Canadian Distributed Infrastructure for Genomics, is a project that we started about 6 years ago to support Canada's very specific data federation needs while trying to remain interoperable. And we focused on development efforts that make CANDIG really Canadian and rely heavily on Global Alliance for Genomics and Health, a international standard-making body that looks to standardize genomics APIs for pretty much everything that we could find: code, standards, privacy regulations, and so on. CANDIG is a GA4GH driver project, so we've been there from day one and have been working to make sure that the Canadian view is also seen internationally, that the way that these standards are being developed are going to work with the Canadian ecosystem. So GA4GH APIs are used everywhere. They're used to access all data. It gives a single interface to a user, easier to work with, and it gives very fine-grained controls to the data custodians so that they can authorize specific users and decide which data sets they have access to. And it also has an abstraction of an underlying data store with fine-grained permissions. Candig participates in a lot of international projects because we're using international standards. For example, we are leading the work in the Seneca effort, where we're trying to connect data standards across Canada, EU, and Africa. And specifically, we're working in the Federated Query Analysis Standards for that. We're also supporting significant Canadian projects such as TF4CN from Terry Fox, Profile, which is a pediatric oncology project from McGill, SickKids, and BC, and Kenkagen, which is the sequencing of COVID patient genomes. And the key part of all of these is that they also are generating data across the country in Quebec, in Ontario, in BC, and each site wants to retain control of its data while also sharing aspects of its data with other ones. Most recently, we've been working on an effort to help develop the Digital Health and Discovery Platform, which is another Terry Fox and Imagia sponsored initiative to connect health data sets at multiple Canadian hospitals. So MOHCCN is trying to sequence cancer genomes, and DHDP is supporting that effort through a federated healthcare ecosystem, but also is building it in a way that will generalize to additional efforts in the future. And this is just a sort of an architectural diagram and what we're working on, creating robust APIs to allow for very standardized data pools at any Canadian hospital, so that when you're deploying a model at any hospital, you can use the same standards. Creating a common network where results of searches across Candig can be combined with results at Imagia which is a federated machine learning system created by a private company called Imagia. It's the Evidence is the name of their actual platform. And building a playground for companies to deploy their own technologies, working with both our open source efforts and with Imagia. So I should mention all of Candig is completely open source. That's one of our big principles. So within the goals of the DHDP project are to enable researchers to utilize advantages of Candig and Evidence, as well as future apps, create robust frameworks to enable commercialization of novel software technologies, build strong security standards for working with federated health data sets, something that is really new. And when you talk to hospital privacy officers, they really are confused about whether you are doing data sharing or not, and need to be often educated. And build a private-public partnership that enables precision medicine across Canada. So with that, I'm going to end and acknowledge both the Candig and the DHDP, the Candig team and the DHDP leadership with whom we've been working very closely on these efforts. Thanks.
Thank you, Dr. Brudno, and thank you to all those who are submitting questions. Some of those have been answered in the chat, and we'll continue the discussion after the next presenter. So our final presenter is Dr. Frank Rudzicz. He is a scientist at the Li Ka-shing Knowledge Institute at the Unity Health Toronto, at Unity Health Toronto, the Director of Artificial Intelligence at Surgical Safety Technologies, Inc., an Associate Professor of Computer Science at the University of Toronto, co-founder of Winterlight Labs, Inc., faculty member at the Vector Institute for Artificial Intelligence, and CFAR Chair in Artificial Intelligence. His work is in machine learning in healthcare, especially in natural language processing, speech recognition, and surgical safety. His research has appeared in popular media such as Scientific American, Wired, CBC, and the Globe and Mail, and in scientific press such as Nature. Thank you, Dr. Rudzicz.
Thank you, and thanks for having me at this conversation on this very important topic. So as was mentioned, I'm associated with a couple of companies. Winterlight Labs works with speech and language data in healthcare, and Surgical Safety Technologies works in surgical data, as you might expect. And we'll be talking about these topics a bit later. So I draw a salary from SST, and I have patents with each. We have a lot of conversations about the various risks of AI, and AI and private data falling into the wrong hands, exposing all kinds of risks. You might have tasks that aren't globally optimal. Individuals could be exposed to non-preferential treatment, exploitation if data is leaked. So another risk is that sometimes, it's not just malicious actors, but people who have good intentions that are trying to deploy AI, but the models we're producing can sometimes result in unexpected or uninterpretable behavior. So we have this problem of so-called black boxes. We want to be able to understand how these models work before we deploy them. And if we want to deploy them confidently, we really need to be able to validate these models on a wide variety of data. But then a third category of risk is kind of the opportunity cost of limiting AI deployment in the first place, and sort of acting as if the technologies we're trying to deploy in healthcare are not fundamentally different than the ones we had in the 1990s, which is not the case, obviously. And so there's malicious actors, there's good actors trying to understand models better before they're deployed, and then there's risks associated with just simply not acting. And I think the solution, or a solution to each of these risks, is really kind of better interaction between different stakeholders, including those in healthcare and engineering technology, which hopefully we'll come to and talk about a bit later. Today, I'm just going to talk about two ways in which we've tried to perform data obfuscation to more or less help in deployment. We want these technologies to really make an impact in the world. So how can we make the data somewhat safer to share, or the models to share? So one example will be about natural language processing with clinical notes, and the other example will be using video data in the operating room. So first, natural language. So traditionally, electronic medical record data is modified by a combination of automated methods, rule-based methods or statistical methods, and human quality assurance to basically search and identify for personal health information. And then sometimes this information is swapped with other information of its type. So a name is replaced with a fake name, or you get these kind of tokens like this is where a name was, or this is where an organization was. Across the literature, there's various rates of accuracy in which this kind of combination of automation and humans can perform, but the best is usually around 99.7% accurate in kind of identifying PHI information in the first place. So just on the side, the back of the napkin kind of calculation suggests that if you have 2 million patients and each of them has just a single mention of PHI in their text data, the best we can hope for is that there's going to be 6,000 unredacted tokens in the data set that we'd want to release to people. And this is how we release it under REB and so on. So under kind of status quo methods. So that's the data. So the data has this inherent leakage of information under current standards. But we want to know if we train a model, a machine learning model on these data, does the model also kind of retain some PHI with it? So just some background, this is a kind of a cartoon example of how machine learning can learn relationships between natural language and say diagnostic codes. This is a bit of a cartoon example, but more modern methods fundamentally follow the same general architecture in which raw data is fed into one end of the network, labels are assigned to the outputs. We try to learn the relationships between these. And then while we learn the relationships, the inside of these networks sort of learn the hidden information between them. So it kind of squeezes information down to what we call latent layers or hidden representations or latent representations. And it's these latent representations with which these neural networks make their decisions. So in natural language processing, we have a medical note. On the input, we have the correct diagnosis on the output, and we learn relationships between these. And then we take these hidden representations and we can project them down into a smaller number of dimensions. Usually the smaller number of dimensions is around 300, but so that we can understand it, we project it down into 2 dimensions. So this is a hidden representation from Mayo Clinic EMR data while trying to learn diagnostic codes. And this is how a neural network kind of understands language. And we can see things and patterns here that are useful to us. So we can kind of see that the neural network is learning something useful. the representation for the word acne or dermatitis or psoriasis all kind of occur in the same space in this latent representation. Cataract, cataracts, glaucoma also occur in the same area. So the point is that through more traditional and modern forms of neural networks that learn representations of natural language, words that mean similar things will cluster in similar spaces in this latent space. That's just kind of some background. So in this paper, the QR code points to a link that points to the paper. So in this paper, we wanted to answer that question from earlier. Does a model retain information, PHI information that we don't want to leak to people? That should it be under the same protections as the raw data itself? So we took embeddings from about 400,000 clinical notes written by physicians. And then using the simple distance metrics, how close this token is from that token, like we saw on the previous slide, we were actually able to reconstruct up to about 70% of the full names of the people that remained in the so-called de-identified corpus. And more than that, we did about 3 or 4 other experiments. We were able to associate other kinds of sensitive information to particular patients. So like the distance between the embedding for a patient and the embeddings for diseases that that patient has are much closer to each other than between the patient and diseases that they don't have. And again, this is only for the individuals whose names or PHI information was kept after this human process of de-identification. But the moral of the story of this paper is, just like there's this 0.3% chance that information will be retained in this de-identified data, this information also bubbles up to the models themselves too, so those models should be secured as well. So around the same time, last year, we also published this paper in JAMIA, where we wanted to try to improve the privacy of the models. And to improve the privacy of the models, we went to try to improve the privacy of the data itself. So we introduced this very simple method that basically took the raw data, and instead of searching for information, like searching for names or searching for diseases or occupations, organizations, and so on, our method essentially replaces absolutely every word in the medical record with another word that is semantically similar to the one we want to replace. And we do that actually by using a pre-trained model like the one we saw on the previous slide. So, the word cataract exists in the data. We have our model. We look for the semantically similar words, one of which is glaucoma, so that in the medical data, we replace the word cataract with the word glaucoma. So every single word is replaced. So in some sense, this ensures complete coverage. So we don't have to worry about this 0.3% of cases which is missed, which sounds like a small amount, but as we kind of alluded to, it can be devastating for thousands of people. But it also covers information that's more hidden, right? So if you have information about family history, that information isn't normally protected using de-identification methods, but this method covers that as well. The end result, hope you can see this, is that the obfuscated data is no longer really readable to humans. So the original note might say something like Arnold Smith is a 50-year-old male with a history of positive of alcoholic cirrhosis. Another thing I should mention is that some of the other methods, they can't handle spelling mistakes really well. So they might miss the word alcoholic here. So traditionally, like a human might say, okay, Arnold's a name, replace it with the token name. Smith is a name, replace it with the token name, and so on. But it'll miss information like, oh, this person fell forward, there's a lip laceration. If you know someone had a lip laceration, that's actually important information, even if it's subtle. So our method that replaces every single word with semantically similar words results in examples like here at the bottom. So if you look, to a region of about 7 words around the word you want to replace, this first note becomes Howard Doug looks the 13-decade monthoid man will, and so on. It also introduces its own spelling mistakes, which is good. So the point is that, you and I can't read this, but a model trained on this data now to detect, say, appropriate ICD codes to diagnose a patient with can still be learned. And as you'd expect, because we're obfuscating the data and we're changing actual information in this data, the model you learn on this data tends to be less accurate. So this graph on the right shows that the more you obfuscate these data, like performance can go down when you're trying to predict ICD codes. But just like in fairness research, a loss of like 2% absolutely can sometimes be seen as acceptable if you're solving a much more major problem, either like improving fairness on one hand, or in this case, further securing the model. So there's a ton of sub-experiments in those papers. I welcome you to look at them to read about that too. So I also wanted to talk about the Aura black box and how we approach privacy here. So the Aura black box essentially is a collection of sensors that's used to assess for risks in the operating room, analyze safety threats and resilience of the team to meet those threats. We assess technical performance, we assess non-technical performance, like how people communicate with each other. So as you can imagine, we have sensors like microphones in the room and a bunch of cameras in the room, which I want to focus on now. So you have like a view of the operating theater from multiple perspectives. So to de-identify this kind of data, it's pretty straightforward, right? You identify humans in the scene using computer vision. So this graph on the left shows a neural network identifying sort of where the people are in the scene. And what we wanted to do initially was literally just transform the data, like that raw video data, into these sort of skeleton structures on the right. So the data would just be these three-dimensional views of like, a dot for the head, a couple of dots for the arms moving around in 3 dimensions. And again, we wanted to do this, the technologists on the team, because like we wanted to make sure we're removing as much information as possible. But when we showed this to clinicians, they said, well, this is not really acceptable. I need to see a lot of detail. I'm willing to put up with a little bit of a loss of recall if I can tell what the hands are doing, because telling what the hands are doing in the operating room can be very important to understand technical skill, or which way the person's head is pointing can be important in assessing distraction, for example. So, there's a kind of a tug of war or a trade-off already between, on one hand, doing things really conservatively and removing absolutely all the information except for where humans are in this 3-dimensional space, and something that's actually clinically useful to people to do all those things we want to do, like assess for risks and so on. This is a little video. I hope it shows up on your screens properly. So this is not the most cutting edge version of what we have, but it's pretty indicative of how we de-identify videos. This is all simulated data. These are real healthcare providers, but this is all simulated data. So again, we identify people with simple neural networks. They're pretty accurate at identifying people, even if it's just a head. We obfuscate the head very rigorously. We obfuscate the rest of the body with this kind of cartoonification effect. There's some pre and post processing. You can kind of see us when the person walks by. I'll try to get that frame. So we kind of extend this sort of like force field, we call it, around people. So if the absolute boundaries of the person are missed by the neural network somewhat, extending this boundary a little bit helps to mitigate against that. And that's important. I'll just mention that, it's one thing to identify heads and remove them, but there's always, like was mentioned in an earlier talk, all this auxiliary information that is in the scene. So if we encountered some situations, for example, where on a few frames, a few pixels of a shoe was visible, and that shoe was a very distinctive color. So if you knew who the person, if you knew, okay, that shoe probably belongs to Dr. So-and-so, I can tell by the arrangement of this room that this is this kind of operation. I can tell by the clock on the wall that it's this time. All this information can be used in theory to re-identify somebody. So we try to mitigate against that. We also identify things in the room like clocks and other things. But maybe we'll get back to this a bit later when we talk about HIPAA privacy rules. But the extent to which you actually try to mitigate against all of these possible forms of auxiliary data is still very much an open question. And different sites will have different requirements. So a hospital in Texas, for example, has a big set of requirements for us to meet when we're talking about HIPAA compliance. Other hospitals we're deploying to are happy with just head obfuscation, and that's it, not even blurring the bodies. I'll just mention that going forward, we're actually doing more stuff on the cloud. So the Blackbox Explorer is kind of a stripped down version of this, where we're not looking at video from the operating room. We're just looking at video from like laparoscopes that are inserted into the body. But even then, videos that are automatically uploaded to this cloud-based platform, the camera comes out of the body temporarily a few times, sometimes to clean the camera, so that when the camera comes out, suddenly you can see the room. So we also apply de-identification even to these kinds of videos, which is much easier and much faster, by the way, but it's still important to do. And we have a bunch of other layers of protection. So this is kind of a screenshot of an older version of Blackbox Explorer. We apply like AI assessment to technical skill, for example. We also apply security. So the reason why you can't see the video here, but I could when I took the screenshot, is because we have DRM that protects videos from being screenshotted and so on. So the last thing I want to mention, I'm not sure how much time I took or how much time I have, but this is kind of one thing that I think is important to mention. I think, we've all been working in healthcare and AI for a while, each of us and many of you. And I think we're at this point where we are up against this kind of somewhat unrealistic model of risk in AI deployment. We often talk at venues like this about issues related to bias, various kinds of safety concerns, like does the model generalize well? What level of error is acceptable? And these are all very important questions. Somewhat of a side note is that rarely does it come up with how biased are humans at these tasks? What kind of safety concerns do humans bring to the operating room? What is the level of human performance in terms of error? It seems sometimes that AI is held to a much higher standard than the status quo, but I think that's important, right? If an AI system is accurate 99.8% of the time and humans are accurate 99.7% of the time, that's still a very big difference. I'm not trying to mitigate, I'm not trying to minimize, real issues of bias, safety concerns, and error in AI. We have to appreciate that. We have to work to help solve those problems. But I think, like those 3 risks I mentioned earlier, we can't really solve those problems. We can't solve risks of bias, safety concerns, and so on, unless healthcare, like technical researchers like those at Vector, can actually work with clinicians and work with the data. Those solutions will be beyond our grasp if we can't have access to the data. But also in terms of deployment, if we do nothing, there's a huge risk. I think there's a ton of evidence that AI, especially in certain deployments, can save costs, improve efficiency, and maybe even improve or save lives. And we can't really measure, a universe that we don't live in, but if we don't deploy these things, we're actually causing harm now and in the future by withholding our progress. And I just want to finalize by, we also do some work in like ethics in AI and ethics in AI in surgery. And I like the metaphor of the operating room, right? The operating room is a very a risky environment, but we're never going to expect risks to be zero. If the benefit outweighs the risks, we still do the procedure, we still proceed. And all we need to do is, through practice, learn what the right procedures are to properly promote safety. Thank you.
Thank you so much, Dr. Rudzicz, and thank you to all of our presenters. I'm seeing lots of questions coming through, and our presenters are trying to answer them for you in the chat. In the interest of time, I think I will turn it over to Roxana to do the poll and give our presenters some time to respond to questions in the chat.
Thank you very much, Melissa, and sincerest thanks to all of our speakers for the expertise that they've shared with us today. We did have a couple of additional polls just to close out the conversation for today and to get a sense of your assessment of what you've learned today and whether you anticipate using pets in the future. So I think those will be popping up on the screen shortly. But once again, I would like to reiterate the appreciation for everyone's time and sharing of knowledge today. I'd also like to thank Melissa for shaping today's conversation. And I'd like to express thanks and appreciation to Andrea Smith, Hope Nestor, and Chiara Lacey for their work in organizing this engaging event. As we've mentioned previously, a recording of this talk will be made available on the Vector Institute's YouTube channel. And once again, thank you very much for your participation and engagement today. We really appreciate it. If you can just take a couple of minutes to complete the poll, we'd really appreciate your feedback. But thank you so much, everybody.